So thank you to Dr. Mariama Evans for joining us this afternoon. Our lecture today is Laboratory Workup for Transfusion Reactions. So our presenter today, Dr. Mariama Evans, is the 2021-2022 Blood Bank and Transfusion Medicine Fellow at UNC's Department of Pathology and Laboratory Medicine. She completed a residency in anatomic and clinical pathology at UNC from 2017 to 2021. Her current responsibilities include clinical service for apheresis patients and administrative tasks related to transfusion reactions and red blood cell antibodies. She is also a 2009 graduate of the University of North Carolina at Chapel Hill and received her medical degree from the George Washington School of Medicine in 2017. In her free time, she currently serves on the executive board of UNC's Resident Diversity Initiative, helping to recruit trainees from underrepresented groups to the institution. So welcome, Dr. Evans. So outside of your your professional biography, what's something unique that you'd like to share with our audience?
Hey, thanks. Well, I don't know if it's particularly unique, but outside of work, most of what I spend my time with is my son, Marshawn. He's a 6-month-old preemie. He was born at 29 weeks, but doing well, and he's very feisty and keeps me busy.
Yes, I can imagine. Oh, sweet. So our poll everywhere question will look like this on your screen. Here is a sample, and you'll have a chance to practice on poll everywhere to make sure yours is working. So our first sample question, many cancer patients require chronic transfusion for anemia and or thrombocytopenia. True or false? And we'll circle back to this question in a minute. So our disclosures today, this activity has been planned and implemented under the sole supervision of the course director, Dr. William Wood, in association with the UNC Office of Continuing Professional Development. The course director and CPD staff have no relevant financial relationships with ineligible companies as defined by the ACCME. Greensboro Area Health Education Center is approved as a provider of nursing continuing professional development by the North Carolina Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. Dr. Mariama Evans has no relevant financial relationships with ineligible companies as defined by the ACCME. So going back to our question, many cancer patients require chronic transfusion for anemia and or thrombocytopenia. So it looks like 100% answered true. How do you think they did, Dr. Evans?
Yep, that's true.
So great, that is working. So now I will hand it over to Dr. Evans.
All right, thank you. So yeah, like she mentioned, I'll be talking about the laboratory workup that we do in the blood bank for transfusion reactions. And as was mentioned, I have no financial disclosures. These are the learning objectives for today. So first I will discuss the most common transfusion reactions that we see and what are their clinical manifestations. And then I'll review what steps are taken when there's a transfusion reaction that's suspected, and then the most common laboratory techniques that we use to work up those transfusion reactions as well. So as was mentioned in the question, many cancer patients do require chronic transfusion for either symptomatic anemia or thrombocytopenia, and platelets in particular are frequently utilized to treat or prevent bleeding in these patients who have extremely low platelet counts. And hemonc patients in particular use a majority of the platelet units that are administered. The cause of these conditions is typically multifactorial, but on the right I listed some of the most common causes. So hematologic malignancy is the biggest one, and as a result of that, sometimes these patients also have hypersplenism or you can have treatment-associated causes like chemotherapy or stem cell transplantation, and also kind of related to cancer patients if they have some type of metastasis to their bone marrow that can also cause them to have cytopenias. And although transfusions are generally safe, adverse reactions do occur sometimes. A death due to transfusion reactions is extremely rare at about a rate of about 1 in 1.8 million. But today mostly we'll be focusing on the most serious transfusion reactions and the most common ones. So the CDC has a group that's defined their kind of very specific requirements to diagnose transfusion reactions, and this is the list that they've made up that contains all of the transfusion reactions that they acknowledge. And today we'll be discussing mostly the acute transfusion reactions. So those are the ones that are commonly seen either during the transfusion or shortly after. So I bolded those: transfusion-associated circulatory overload, which is also known as TACO, TRALI, which is transfusion-related acute lung injury. Those are both very rare. Allergic reaction and febrile non-hemolytic transfusion reactions, which are more common. And then we'll also briefly talk about transfusion-related sepsis and then acute hemolytic transfusion reaction. So how frequently do these occur? As I mentioned, allergic and febrile non-hemolytic are the most common ones at about 1%. And then the ones that we see hardly ever or rarely would be TACO, which in the literature they say less than 1% of transfused patients, although it's thought to be higher in hospitalized population, and we'll briefly discuss that later as well. And then the ones that hardly ever occur would be TRALI, transfusion-related sepsis, and then acute hemolytic transfusion reaction. And later on, I'll be talking about some of the steps that we take to prevent those three transfusion reactions from occurring. So this is a good chart that just kind of compares all of the adverse effects of RBC transfusion in comparison to your everyday fatalities. So as I mentioned previously, transfusion reactions very rarely can be fatal, and these fatalities are generally less common than your everyday fatalities, so like falls or motor vehicle crashes. However, the life-threatening reactions are more common than, as you see, HIV, HCV, HBV. So you're more likely to have a life-threatening reaction in comparison to acquiring an infectious disease from a blood transfusion. So this is the first transfusion reaction that we'll be discussing, allergic transfusion reaction. So that can range from either mild hives to the most severe form would be anaphylaxis, which, as you can see, is extremely rare to have an anaphylactic reaction to a blood product. Typically, patients will have hives and itching, and this is thought to be related to the patient is having a hypersensitivity reaction to some allergen that was in the donor's blood. And we most frequently see these with platelet transfusions. On the right side of the slide is just the CDC definition that they use to identify allergic transfusion reactions. So flushing, hypotension, lip swelling, and those things. For mild cases of allergic transfusion reaction, typically you can just give antihistamines with or without steroids if it's a more severe case. And if there's anaphylaxis, obviously you would give epinephrine. And then on our end in the blood bank, we would wash the patient's units just to remove some of those potential proteins that are in there. And this is something that we most commonly would do in a patient who lacks IgA, and particularly an IgA deficient patient who makes IgA antibodies. So that's your typical test question of what kind of patient would require RBC washing. Let's see. The next transfusion reaction, and we're going from more common to less common, is a febrile non-hemolytic transfusion reaction, and we also see these pretty commonly. We do something called leukoreduction to the cellular blood products. So basically we remove the white blood cells that are present in the unit via a filter. And the reason why that's important is white blood cells can release cytokines, which will stimulate the immune system. So we want to remove as much of those as possible. And febrile non-hemolytic is most commonly seen in red blood cell and platelet transfusions. And typically we're looking for a fever with a rise in body temperature by 1 degree Celsius. And we also look for whether or not the patient had chills or rigors. And sometimes we'll recommend just treating the patient with antipyretics if the primary team thinks that it's clinically indicated. So typically we recommend Tylenol. So transfusion-related sepsis is the next one, and this is extremely rare. It will generally manifest as a high fever after a transfusion, and then the patient will also have hypotension, chills. The incidence varies by blood component, so it can be seen in 1 in 100,000 recipients, but the fatal cases is closer to 1 in 500,000. And it will usually occur within 4 hours of the transfusion. And typically we believe that the source is either due to skin flora that was present on the donor when the unit or the blood product was collected, and then also less commonly red blood cell units in patients that have an asymptomatic bacteremia. And I listed the ones that are most common for that, so Yersinia, Pseudomonas, and Serratia. And typically, transfusion-related sepsis most commonly is seen with platelet units because they're stored at room temperature. And depending on what the patient's temperature is, like here in our lab, if the patient's temperature is greater than 39 degrees Celsius, that will trigger it to be sent for culture to see if there's anything there. And just as far as gram-negative bacteria typically cause the most severe symptoms, so those can cause shock, renal failure, DIC, so those are the ones that are more commonly fatal. And kind of the last thing is just that if you think that your patient got sepsis from a blood product, that's something that the blood bank needs to know, because then we have to let the blood center know so they can quarantine other units that might have been collected and possibly contaminated as well, and also try to see if we have any other blood products that could be contaminated from that donor. Next, kind of moving on to the more rare and more serious conditions. So TRALI is very rare, and it's basically a life-threatening non-cardiogenic pulmonary edema. So you'll see hypoxemia, and on the chest x-ray there'll be pulmonary edema. And we'll go over on the next slide what is the pathophysiology behind that. But the signs and symptoms include fever, shortness of breath. We would be looking for some hypoxemia and other clinical features consistent with that. And really the most important thing for TRALI is that the patient cannot have had any evidence of acute lung injury prior to the transfusion. So typically those are the first things that we're looking at when we get a consult that someone thinks a patient might have TRALI. We're trying to see what are they admitted for and what was their condition that brought them into the hospital. And there are some risk factors listed there: chronic alcohol abuse, patients who already have shock or sepsis and current smokers. And on the next slide, we'll kind of talk more about that too. Okay. So TRALI is thought to be related to a two-hit hypothesis. So the patient prior to transfusion is primed. Their kind of immune system is primed because of some other systemic inflammation or medical condition. They have neutrophils that are sequestered in the small vessels in their lungs and already primed by cytokines. And then the second hit occurs when there are HLA or anti-neutrophil antibodies that are present in that donor in the blood product unit that are then transfused into this patient and activate their neutrophils, resulting in more cytokines being released, and then the pulmonary capillary endothelium becomes damaged and causes pulmonary edema. And I thought this was a good representation of what typically happens. So on your left side, there are donors. If they have a history of pregnancy, it's the most common instance where we'll see somebody who has HLA antibodies. So if a woman's been pregnant, especially if she's been pregnant multiple times, that's a high risk for having HLA antibodies. And other patients who have been previously transfused or transplanted are also likely to have HLA antibodies against those foreign antigens. So when TRALI does occur, the rare times that it does occur, we would have to, well, the blood center would have to identify what donor was affiliated with that unit that was implicated, and that person would be permanently deferred from donating anymore. So yeah, TRALI, it's believed that those antibodies are transfused into the recipient who's already been primed to have a reaction due to their main condition. So imaging is pretty critical in the diagnosis of both TRALI and TACO. And as I mentioned, there'll be pulmonary edema, and that's due to the leakage of fluid into the alveolar spaces. And typically on our end, we're just looking to see if there's any signs of heart failure, because that would point more towards a circulatory overload diagnosis. So in this picture, boxes B and C both have the bilateral opacities consistent with TRALI and pulmonary edema. And then in box D, which is 72 hours after the transfusion, there's partial resolution of their pulmonary edema. So moving on to TACO, TRALI and TACO often are compared and kind of on the same differential because there's a lot of overlap in their symptoms. So TACO is similar, but it's believed to be cardiogenic in origin instead of non-cardiogenic. Both conditions will have acute respiratory distress, but in TACO we're looking for evidence of volume overload. So that would be exam findings like crackles on the lung exam, or if they have peripheral edema or jugular venous distension. And we'll also be looking at their vitals to see if they have hypertension. And typically the biggest lab result that we're looking for is a BNP. So if there's an elevated brain natriuretic peptide level, that is consistent with the cardiogenic involvement. And that would point us more towards a diagnosis of TACO. And TACO is thought to occur in less than 1% of transfused patients, though it's slightly more in hospitalized patients. And we'll discuss kind of what are the risk factors on the next slide. So this is just a comparison to kind of compare the TRALI and TACO. Fever is more commonly seen in TRALI, And then the kind of distinguishing feature for TACO is going to be volume overload. And also it will improve with diuretics. So that's typically what we want to see. If we think it's TACO, does it get better once diuretics are administered? But it can be challenging to differentiate between them in a patient that's critically ill because there's a lot of overlap in their chest x-ray and their symptoms. But typically we're looking to see that the heart size is increased on the chest x-ray for TACO. And also we look at the patient demographics a lot. So surgical and ICU settings where large amounts of fluids and bloods are being administered is going to be a risk factor for TACO, especially if a patient is already predisposed to having kind of fluid overload. So patients who have impaired cardiac function, especially either very young, like infants and small children, as well as elderly patients. So we always say the extremes of age are also an increased risk for having TACO. And most commonly for us, we see that in kind of older patients, especially cancer patients who might be getting a lot of blood products transfused. I believe this is the last kind of more acute transfusion reaction that we'll be talking about. So acute hemolytic transfusion reaction, it's rare. It's an immune-mediated hemolysis that occurs due to transfusion of incompatible red blood cells. And typically the onset is going to be fairly rapid, but the official diagnosis says within 24 hours of transfusion. And that's just to distinguish it from a delayed hemolytic transfusion reaction, which occurs longer than 24 hours after transfusion. So AHTR is the third most fatal transfusion reaction. It's typically due to human or clerical error and sometimes record fragmentation, so that if that's a patient that's visiting multiple hospitals, that can be a factor if we don't have a complete blood transfusion history on them. So as far as the findings that we're looking for, we would perform a DAT, and we'll go over what's done in the DAT shortly, but we're looking for a positive DAT, and that's basically where there's antibodies that are attaching to the red blood cells. And then we're going to look to see if they have any evidence of an alloantibody that could be causing the hemolysis. And typically AHTR is most commonly due to ABO incompatibility. And hence that's why it's most often due to human or clerical error, because it's commonly due to a mistake where somebody was given the wrong blood or the wrong patient or the wrong label and things like that. And there are some other non-immune mediated causes, but we won't be discussing those today. But just as far as labs to order, if you think that a patient could have an AHTR, you're going to want to order the hemolysis lab, so bilirubin, haptoglobin, and LDH. And then sometimes if you have a high clinical concern, you can get a urine sample and we can look for hemoglobin in the urine. And then on our end in the blood bank, we're also going to look to see was there an adequate increase in their hemoglobin after transfusion. And then we'll also spin down the sample, the post-transfusion sample, to see if it's discolored, which would be if it's brown or red. That might suggest that there's hemolysis going on. And I think maybe I forgot to mention, but TACO and TRALI are the most common fatal transfusion reactions. So TACO is the most common, and then TRALI is the second most common, and then AHTR is third. So this is just a drawing that shows kind of all the things that are happening during AHTR. So as I mentioned, the red blood cells interact with the antibodies, and these are the incompatible donor red cells that have been transfused. So typically that would be a patient who makes anti-A or anti-B antibodies just naturally. And essentially when the antigens and the antibodies bind, that activates complement, which will then go on to result in red cell lysis, and then also cytokines are released. So you can have the outcome of fever, renal failure, hypotension, DIC in serious cases, and as I mentioned previously, hemoglobinuria. And on the right, those are just the many things that we're looking for based on the CDC definition. So we'd want to see those labs showing evidence of hemolysis. And then you would kind of want to figure out if it's immune mediated or non-immune mediated. So typically if the patient has a positive DAT and we can find evidence of an alloantibody, then that would be consistent with an AHTR. And as I mentioned, DIC can be kind of the most fatal outcome of AHTR. So that's when your coagulation factors and platelets are being consumed. So this is a complication of AHTR, and it's excessive complement activation. And you can see schistocytes on the peripheral smear. I included a picture there. And then also the most common findings for DIC would be expected. So the elevated PT, PTT, D-dimer, and then decreased fibrinogen. And for that, the treatment would just be supportive care. So hydration, supporting their blood pressure. And if they happen to need more blood products, that could be administered as well. So overall, there's been a decline in deaths related to hemolytic transfusion reactions, and the number of reported deaths is quite low. ABO incompatible transfusions now kind of make up a majority of reported deaths, and as I mentioned, typically that's due to human and clerical errors. And also now I think there's just a lot of effort put into getting complete transfusion histories and having better records that would prevent a patient from being transfused incompatible blood. So here is the next question. Which one of the following is not a reaction to transfusion? So we have febrile non-hemolytic transfusion reaction is A. B is transfusion-related sarcoma. C, transfusion-related acute lung injury. D, transfusion-associated circulatory overload. And E, acute hemolytic transfusion reaction.
Just give our audience a couple more seconds to chime in, but
okay.
Looks like we're all consistent with B so far. How'd they do?
Yeah, so transfusion-related sarcoma is not, it doesn't exist, and transfusions are not known to cause cancer. So that's correct. So I just included this to look at kind of the breakdown of transfusion-associated fatalities. All transfusion-associated fatalities must be reported to the FDA, so that's why it's important that the blood bank is notified about transfusion reactions, and they publish an annual report, which this is from the most recent publication. Overall, the number of reported fatalities is fairly low, but there's speculation that some of these are underestimated since some transfusion reactions are not diagnosed or not reported to the blood bank. And as I mentioned previously, taco has the highest number of fatalities at 34%, and then TRALI is second, and hemolytic transfusion reactions are third. So overall, there are lots of signs and symptoms of transfusion reactions, and that's it's important to document any and all symptoms that a patient is having that could potentially be related to the transfusion. Typically, we look at timing in relationship to the transfusion, and vitals as well will point us towards a certain diagnosis. So this is a good chart that is helpful, kind of looking at whether or not the patient has fever and whether or not their reaction was acute. So within some time near the transfusion, or if it was delayed. And kind of acute, serious and fatal reactions can occur quickly. So a lot of the most fatal ones are under the acute section. And as I mentioned, it's important to do frequent vital signs during a transfusion. We especially like to look at the pre and post transfusion vital signs as well to compare what the changes were. And specifically for acute transfusion reactions, if the patient has a significant fever, that can point towards TRALI or febrile non-hemolytic or sepsis, depending on what the other signs and symptoms that they had. So really just documentation of everything that happened is helpful to us to be able to figure out what diagnosis we think it could be. So if a transfusion reaction is suspected, the first step is always to stop the transfusion and maintain IV access in the patient in case they happen to need medications or fluids. Obviously assess the patient and treat whatever reaction they're having. Then thereafter, we recommend doing a clerical check. So confirm that you have the right patient as well as the right unit. And when the unit is sent back to us in the paperwork, we do clerical check as well to confirm those things. And also important, inform the blood bank and obtain either post-transfusion blood or urine samples, depending on what the potential diagnosis is. And we also like to have the remaining blood product back in case it needs to be cultured or we need to test it further. Our transfusion reaction paperwork will ask for symptoms and then vitals, as I mentioned, plus any other medications or fluids that we're running during the same, running at the same time. So now moving into more of the laboratory things that we do. As I mentioned, at the bare minimum, there will always be a clerical check that will ask if the names and the paperwork match the patient and are the labels correct. And kind of how much we do will depend on what type of reaction the patient had and how serious it was. But mostly at a minimum, we do a clerical check. We can do a visual check for hemolysis, so we can spin the sample down and look to see if there's any gross hemolysis like in this picture. And then we often will repeat the ABO type to see if it's correct and appropriate. And as I mentioned, DAT can be performed to see if there's any antibodies or complement that's covering the red blood cells. And if the DAT is positive, we can also do antibody screens and things to look for an antibody. Oh, and as I had mentioned, we can do, if we have a high suspicion for sepsis or a contaminated unit, then we can do a gram stain and culture of the return product. So that's specifically if a patient has signs of sepsis and they have a high fever. So this was a good example of what potential steps you could take if you're suspecting acute hemolytic transfusion reaction. On our end, we will repeat the ABO typing on the pre and the post-transfusion sample to see if there's any discrepancies. And you can also draw those, as I mentioned, the hemolysis labs, or if you're concerned for DIC, you can check the PET or the PTT. And also, if you're concerned for renal involvement, you can check a BUN or creatinine. If the DAT is positive on the post-transfusion sample, we'll look for an antibody, either via an eluate or an antibody screen, which will be what we'll go over next. And as I mentioned, we can spin down the serum or the urine to look for any discoloration that might be suggestive of hemolysis. So hemoglobinuria is something that can happen when you have AHTR. Similar to in the serum, you get excess free hemoglobin that can be seen in the urine when it overloads the renal threshold. And if you have hemoglobin in the urine, that confirms intravascular hemolysis. And in this picture, I just thought it was a good comparison. They're comparing hematuria, which is red blood cells in the urine, typically due to something that's wrong in the urinary tract. And hematuria will resolve with centrifugation compared to hemoglobinuria, which will stay red once it's centrifuged. So that's another thing that we can do to look to see if there's excess free hemoglobin in the urine. For ABO typing, we would want to repeat this to confirm that there were no discrepancies between the forward and the reverse type. So the forward type, we use reagents where there's a known antibody present, and we will combine it with the patient sample to see what they react to, and that will suggest what ABO antigens are present on their red blood cells. And the reverse type is kind of exactly what it sounds like. Instead of using known antibody, we use known red blood cell reagent and see what antibodies does the patient have in their plasma. So for example, if a patient is blood type A, they have A antigens on their red blood cells. And when we do their reverse type, it should show that they have B antibodies in their reverse type. So especially for red blood cells, we want to do ABO typing to reconfirm that the unit that was given was compatible with the patient's ABO type. So this is the next question. What is the first step to take in the event of a transfusion reaction? A is clerical check, right patient, right unit. B, visual check for hemolysis. C, ABO, RH typing, and DAT. D, stop the transfusion, or E, call the blood bank.
We're getting a mix, but I'd also add, I think some would be calling for infusion APPs to the rescue, who provide a lot of care for our infusion patients when these reactions happen. How'd they do?
Yep, that's correct. The very first step would be to stop the transfusion. That way you don't continue giving them something that might be harmful. And then after that, yeah, you can make sure the patient is stable and call for help as well. Okay, so beyond the ABO blood types, there are lots of minor antigens that are present on the red blood cell surface. Some are high frequency and seen in almost all individuals, and then others will vary by ethnic origin. So patients can develop antibodies against these minor red blood cell antigens, and when we're working up antibodies, that's typically what we're working up, antibodies to these antigens that are minor antigens, so non-ABO. And this is particularly in patients who have a history of prior exposure, so during pregnancy or kind of chronic transfusion history. And typically we want to identify what is the antigen that they have an antibody to, because that can tell us more about kind of the behavior of the antibody and what's likely to happen to the patient. So for the DAT, we'll use a post-transfusion blood sample, and we'll essentially add what's called the AHG, which if it's present in the presence of donor red blood cells that are covered with antibodies, you'll get agglutination, as it shows on the top column, positive DAT. If there's no antibodies or complement on the red blood cells, then you'll have no agglutination, and that will be a negative DAT. And so that's our first step if we're looking on the more serious transfusion reactions, to see if there's anything that's covering the red blood cells that could be causing this reaction. As I mentioned, if there is a positive DAT, we can do what's called an elution, which will just disrupt the attachment between the RBC and those antibodies. So there's multiple techniques, either heat, acid, organic solvents, that will disrupt those forces and kind of push the antibodies into a solution that we can test for specificity. And the way that we'll do this is this is kind of a good example of the acid elution. So they add it to the specimen, and then it will dissociate those antibodies. And then we can test that solution containing the antibodies against a reagent, a panel with reagent red blood cells, where we know what antigens are present on those red blood cells. And that can tell us the specificity and identification of the antibody. So this is helpful both in the diagnosis of hemolytic transfusion reactions and if there's suspicion of hemolytic disease of the fetus and newborn and things like that. And this is kind of, I just wanted to go over briefly what the antibody screen is, just for clarity. So essentially we're asking if there are any antibodies in that person's blood that could cause a problem if it's mixed with someone else's red blood cells. So for the antibody screen, we'll take the patient's serum, which potentially has red blood cell antibodies, and similar to the elution, we'll combine it with a panel that has reagent red blood cells, where we know what antigens are on those red blood cells. Then we look for agglutination, and we'll kind of compare which cells they react to, and kind of, let me move to the next slide and see if I can show it better. Yeah, so basically we have this panel where we have different cells that have different antigen profiles, and we'll try to figure out, oh, this patient reacted to cells 2 and 3. So which antigens do they potentially have an antibody to? So if a patient has more than one antibody, it can become complicated and take more time. Sometimes if it's a rare antibody, it may need to be sent out to the Red Cross immunohematology lab. So sometimes these can take a while if it's something that's rare, that's not commonly seen. But we also can use the strength of the agglutination. If a patient has more than one antibody, the strength of the agglutination can be helpful to tell us that. And then we can kind of find various cells with different profiles to rule in or rule out potential antibodies. it's all very complicated, but that's kind of the most simple explanation of that. And then, yeah, in the setting of a positive eluate or a positive antibody screen, we'll want to identify those antibodies. That's really important, as I mentioned, for hemolytic transfusion reactions or hemolytic disease of the fetus and newborn, mostly because those patients will need antigen negative units if they ever require a future transfusion. And as I also mentioned, once we know what antibody is, we can speculate on the clinical behavior, and some antibodies are more fatal or more clinically severe than others. So that's helpful as well. And some also can be fairly clinically insignificant and versus others that are highly fatal. So we do want to identify those. That way we can document them. And if the patient goes to another hospital, they can call us and find out that patient's transfusion history, and we have a kind of computer system where we keep track of all histories of antibodies that have been proven in that patient. And this is just more of how we identify antibodies. So it's similar to the antibody screen, it's just more extensive. We use more cells to try to see what, both whether or not there's agglutination and what's the strength of the reaction. The FDA requires that all of these antibodies on the top right be tested. So it's a pretty extensive list, but these are all the ones that are clinically significant. And just in terms of cancer patients, sometimes medications can interfere with our testing. So specifically daratumumab is one that the anti-CD38 is present on RBCs, and thus it can mask whether or not there are alloantibodies present in our testing. So this is the last question. Elution techniques disrupt the attachment between RBCs and the coding antibodies. True or false?
I think this is our last question. So if you get your questions ready for Dr. Evans, and you can submit them through Poll Everywhere as we get towards the end of her talk. How'd they do?
Yep, so elution techniques like heat and organic solvents can disrupt the attachment between RBCs and coding antibodies. That way we can test the solution that remains and see if we can identify what the antibody is. So this is my last slide, just kind of summarizing what are the key points. As I'm sure we all know, blood transfusions are generally safe, but they're not without risk. And it's important that if you are supervising a transfusion, that you just document the patient's symptoms and their vital signs, because that will help us to be able to determine determine our differential diagnosis. For patients that have complex antibody panels, sometimes we require additional sample to send out to reference laboratory. And that does commonly happen, especially in patients that have been multiply transfused. And then lastly, your transfusion medicine service can advise regarding the diagnosis of transfusion reactions and help with determining whether or not a patient has special blood product needs, especially patients with red blood cell antibodies.
Thank you very much for this great talk. Here are references, and please submit questions for Dr. Evans through Poll Everywhere. While we're waiting for some questions to come through, a what are your comments about rate of infusion for blood transfusions? I'm not sure if they play much of a role of reaction, but you know, I grew up an infusion nurse for many years, and we usually transfuse over 2 hours. Lots of times people are transfusing over an hour. So can you just share like what your thoughts are about rate of infusion of transfusions? And obviously in a fluid overload status, we want to be mindful of rate of infusion, but anything to comment on regarding rate of infusion?
Yeah, I was going to say specifically for TACO, the transfusion-associated circulatory overload, that's one of our recommendations, is to transfuse slower if the patient still needs blood products. I think that's the main one that comes to mind as far as the rate of infusion. But yeah, for the other ones, we don't typically make recommendations, but yeah, I would say it's really up to you all.
Mm-hmm. So next question, are there any injection site reactions that are commonly seen and have any special considerations?
There aren't any that I know of. We don't commonly get injection site reactions reported to us. More on the donor side, we look for kind of things like that, or if they have any, if their skin is disturbed or things like infection we look for, but I don't think that we typically hear about injection site reactions too much.
And another question, what type of patient education is typically provided when a high-risk patient for TACO is receiving a transfusion?
And that's a good question. I've never really thought about. I mean, I guess you could just advise them of what the risks are and what you will do to kind of monitor those risks. So as I mentioned, transfusing slowly, and also just, I guess, being mindful of whether or not the patient, do they badly need the transfusion? So you can kind of reassure them that their vitals will be monitored, and at any point the transfusion can be stopped either by patient request, or if there's something unusual going on. You could tell them about the symptoms to look out for. So shortness of breath and things like that would be something to let them know if you think that a patient is high risk for having circulatory overload.
And additionally, is there a particular allergy that is more common in a recipient that would increase the risk of a severe reaction? Does the screening process account for this?
I think sometimes, just anecdotally, probably peanut allergies would be the most common one that's mentioned. I don't think that, I don't know that we do anything to prevent people who have eaten, say for example, if somebody had a peanut butter and jelly sandwich before they donated, I don't think that that would mean that they couldn't donate. But if there were a patient who had a severe allergy to something, it could maybe be something to ask the transfusion medicine service what they think about whether or not the patient needs washing of their units to prevent that kind of anaphylaxis from happening.
Great.
So the short answer is no.
Okay. Are there any long-term symptoms for patients who survive a transfusion reaction, and how do you deal with them?
I don't think, I mean, really the main one that probably could have long-term symptoms would be acute hemolytic transfusion reaction. But since that's so rare, I'm not sure as far as how frequently that happens, but for the more common ones, there's typically not long-term symptoms. Even TACO and TRALI would eventually resolve for the most part, but I think acute hemolytic transfusion reaction maybe if you had renal failure and DIC and the more severe complications, that maybe that could result in long-term complications.
And then our next question, what do you do with a patient who needs a transfusion but is a hemophiliac?
That one I'm not too sure of. We haven't really had that come up. That one I'm not sure.
How can we better prevent AHTRs for patients without a history of transfusion reactions?
Well, because it's usually due to human or clerical error, typically that would be just being diligent about making sure that you have the right patient and all of the steps that you're required to go through, and kind of on our end in the blood bank, not rushing and just trying to make sure that we don't skip any steps that might result in the wrong patient getting, the wrong patient getting the wrong unit.
It looks like we might be wrapping up our questions. Thank you so much for sharing this topic with us. I appreciate you spending the afternoon with us. And thank you to the audience for attending. Thank you to the University Cancer Research Fund, to the UNC Lineberger Comprehensive Cancer Center, and our Lineberger Cancer Network telehealth team. Our behind-the-scenes team are rock stars and make all this happen. Thank you to Tim Poe, Mary King, John Powell, Jason Paler, Benny Abiori, Oliver Marth, and Andrew Dodson.